Fiona from Health. Yeah.
Okay. Chairman will I.
Okay. Good afternoon, everybody, and welcome to the West Berkshire Health Scrutiny Committee. I'm Councillor Martha Vickers, Chairman of the committee. The members of the committee with me here today are Councillor Stuart Gawley, Councillor Owen Jeffrey, and Councillor Nigel Foote, who is here substituting for Councillor Nick Carter. Councillor Alan McCrow is also present as Executive Portfolio Holder for Adult Social Care and Health Integration. Council officers and external partners joining us to advise and support the meeting are Paul Coe, Interim Executive Director of People, soon to be Executive Director of Adult Social Care. And Fiona Warby of Health Watch, hopefully may be joining us. She's with us. And Fiona Warby, Lead Officer from Health Watch, and from Buckinghamshire, Oxfordshire and Berkshire West Integrated Care Board. We'll have Sarah Webster, Executive Place and Director for Bob and ICB, Helen Clark, Associate Director of Primary Care, Dr. Heike Veltman, GP Thatcham Health Centre, Liz Hodgkinson, Assistant Director of All Age Continuing Care, Nikki Cartwright, Director of Vulnerable People Services, and Lisa Shoebridge, Programme Director, Urgent Care. They're not all with us at the moment, but hopefully will be joining us later. Vicky Phoenix is the clerk for the meeting. The meeting is also being live streamed by YouTube, and Gordon Oliver is the Zoom host. Before we start proceedings, I'd like to explain for the benefit of members of the public who might be watching that this afternoon's meeting is being held both over Zoom and with councillors present in the council chamber. The meeting is being live streamed on YouTube, so members of the public are able to follow proceedings. Please can I ask everyone participating to make sure they switch on their microphones when invited to speak and to switch them off when they finish speaking. If we hear the evacuation alarm this afternoon, we must leave the building immediately via the emergency exit. The assembly point is the Dolphin Car Park. If the lockdown alarm sounds, we will remain seated and await instructions from officers. We'll adjourn the meeting until such time as it is safe to proceed. Do members have any questions about the way in which the meeting will be conducted? They're all shaking their heads. No. Okay, so item 1 is apologies. Vicky, do we have any apologies?
We've received apologies from Councillor Jane Langford and Councillor Nick Carter. Councillor Nigel Foote is substituting.
Thank you. The minutes, we need to confirm that the minutes of the meeting held on the 13th of June 2023 can be approved as a true and correct record of the meeting. Do I have a proposer? Okay, Councillor Foote.
Yeah, I'm happy to propose those as a true record, Chair. Thank you.
Councillor Foote, and a seconder. Item 3, members are asked to note the progress in relation to actions from previous meetings. That is on page 11. Do we have Sarah Webster? Oh, we do. We have a specific action there for Sarah Webster as regards surgery. Does Sarah want to comment?
Hi, yes. So a written update will be sent through in terms of this action, and we've got a section on the agenda today about primary care, so we can cover some of the specific points off under that agenda item today.
Okay. Do members have any comments, other comments in relation to the update? Councillor Foote.
Yeah, thank you, Chair. Could I ask, will we get ongoing updates on the dementia diagnosis and diabetes, the pre-diabetes assessments that were highlighted in the previous meetings? Because if from memory, the dementia diagnosis we wanted to try and improve that, and it would be quite good to know what progress is being made. And similarly with the diabetes aspects, you know, these are ongoing problems, and it would be quite nice to get regular updates on how we're progressing on those. Thank you.
I'll ask Vicky to confirm, but we have got in the notes on that item that an update will be scheduled into the work programme. So do we have any further comments, Vicky?
No, I think it was agreed an annual update, but we can ask them more regularly if that would be helpful.
Would that be good?
Yeah, an annual update would be fine. I'm sure it's just so that it doesn't get lost. Thank you.
Well, if we think we want a 6 monthly or something, you know, we can consider that too. If we think a year is too long, if we think the things are more urgent, but you know, that's something to get back on. Right, thank you for that. I need to declare that I'm a member of the Health Watch Board. Okay, anybody else got any declarations? No, thank you very much. Item 5, do we have any petitions?
We've not been notified of any in advance of the meeting.
Thank you, Vicky. Right, item 6, which is the first substantial part of our meeting, and this is to receive a report from Helen Clark, Associate Director of Primary Care, Bob and ICB, Dr. Heike Veltman, GP Thatcham Health Centre, also Sarah Webster, whom you've just heard at the meeting, Executive Place Director, Bob and ICB, about access to primary care. Thank you very much. Over to you.
Hi, sorry, I was just sorting my camera. So I think Heike has just joined the meeting and is going to be taking us through the paper.
Can I just check that you can hear me all right and see me?
Yeah.
Lovely. If you don't mind, I'll try and share my screen.
Thank you.
Can I ask if you can see my screen okay? Yes?
Yes, thank you. Yes, we can.
Okay, excellent. Thank you. Do I need to make it bigger, or is that okay for you to see?
A little bit bigger if possible, I think.
Let me see if I do that. Does that help?
To fill the screen.
Is that working?
It's good. Thank you.
Okay, excellent. So thank you for this opportunity to speak to you about access to primary care. My name is Heike Veltman. I'm one of your local GPs, but also here in my capacity as one of the clinical leads for Bob ICB. And with me, I've got Sarah Webster and Helen Clark, which will hopefully be a backup and able to answer all of your questions. Today's format is going to take on 3 main areas: access to primary care and the latest position, the primary care recovery plan, and then working with other services. The next 3 slides is going to look at specific data sets. So we're going to be looking at recent surveys, activity, and time to booking. As you will notice that there's quite a bit of variation, but then we'll have a follow-up slide, an important, where mitigation and support have been put in place to help address these variations. So if we look at this slide, we've got 13 practices across 4 PCNs within West Berks. This table here is the GP survey, patient survey from July 2023. On here you can see there's huge variety varying from a few practices that are in the top 10 best performing. And however, there are no people in the lowest 10 performing. There's a friends and family test feedback there as well. Sadly, this is only a one-liner. I think it should have as much importance, and hopefully you'll see a big variation in achievements on that. This slide takes into consideration the appointment activity. And first and foremost, on this slide, I'd like us to stand still and just look at the sheer volume of activity that we're dealing with, over 70,000 appointments per month. West Berks, and this is the total number of appointments, and then it divides it into face-to-face, telephone, visits, and online consultation. What this doesn't show is how activity has systematically increased over the past few years, but it just gives you a flavor of the past few months. West Berks' position in delivering face-to-face appointments is 60.4%, as compared to the Bob position of 62%. From my perspective, the important thing, so this is with my GP hat on, an important question to ask is rather, what is the most appropriate consultation time? You know, how are we going to help address the patient's need? And how are we going to help to address the presenting problem? Because those two need not be the same thing. And then importantly, what is at the core of GP, how are we going to deliver ongoing care? This slide looks at time to booking appointment, with the government's target of achieving 85% within the next 2 weeks for appointment time. And, you know, Berkshire West is faring fairly well, I think, for the short period of time that we've had to put this in place. 81% achieving that 2-week appointment booking. And this obviously comes at the cost of how on the day appointments. And I think there's always has to be a healthy balance between what is routine care and what is urgent care. And I think my personal viewpoint, if we get it just right, if we have better routine care, there'll be fewer on the day demands of emergency sort outs that we require. But if you look at performance yet again, Berkshire West performing at 81% and performance across Bob at 87%. So for me, this is the important slide. Having seen the variation that we have within West Berks, how are we supporting our practices to deliver more, to level up? And it's important to this first statement, because this is looking at those data sets, the GP survey, the friends and family. It is important to triangulate our data feedback because there's variation in everything, and we need to take it into consideration. So not just the GP survey, but friends and family. And we also make use of soft intelligence, what we're hearing on the ground. We need to take into consideration what other changes are happening within that practice. You know, there might be more illness, there might be a few resignations, teaching and training. So that takes up time to upskill people with a changing practice to be able to deliver more. So all these things need to be taken into consideration when we're doing these reviews. The next thing that is being put in place is the PCN capacity and access improvement plan. And this is actually an investment in PCNs to see how they can help identify areas that need improvement. And I'll talk to you a little bit more about some of the plans that they've put in place. Then we do some more focused, targeted discussions and practice visits where we see a few outliers and multiple different measures to help support that practice. And then we've got a few tools that are being rolled out to practices to help manage capacity and demand. So looking at those things a little closer, and how can we do things more slick? How can we use digital more, and so forth? And lastly, here is the recovery plan, the rolling out of recovery plan. And I'll be talking to this in the next slide. So the recovery plan is divided into 4 main sections: empowering patients, modernizing GP, cutting through bureaucracy, and building capacity. I'll hopefully be touching on all these elements and focusing more with my GP hat on where I think is our best bet. And this first slide here, empowering patients, I feel very strongly that this is our area of greatest opportunity of where we're able to make a difference. I feel it's an untapped resource because all the other things are limited. There's limited workforce, we've got limited money, but at the end of the day, all of us are patients. And what I would like us to do is see, how can we care better for ourselves? And when we look at this, there's an opportunity of making better use of the NHS app. Through that, we're able to book our appointments and need not then wait on the telephone line to wait in line to get through. We're able to book our medications through the app and so forth. Self-referral pathways. You no longer need to speak to or see your GP first to be able to have a physio referral. You can now self-refer to a physio, skipping out that middleman. There's huge opportunity of what we can do with our community pharmacies. Our community pharmacies are now seen as the wider extended element of primary care. They can do some minor illness. You know that more and more medications are available over the counter that previously you would have required a prescription for. Our pharmacy can now also do blood pressure checks for us to identify and help prevalence. And then lastly, the self-monitoring. More and more people now have their own blood pressure monitors. They're knowing your numbers, and this is absolutely fundamental in how we keep ourselves healthy. Modernizing GP practice. The advanced telephony system is another example of how we hope to help unblock the feedback on telephone access within general practice. 10 of our practices already have this advanced telephony, and the 3 that don't have it are on the waiting list to get it. So it is absolute work in progress. Care navigation. We used to think of our receptionists as just receptionists. Now we're doing active training to help support development of our reception team as care navigators to help steer and help patients see the right health professional. So through 111, through our community pharmacy, or whichever is the most appropriate clinician within general practice. And then there's also some training packages that is available to practices. And this is how to bring about change, looking at processes, how to do that smoothly. And I mentioned previously examples of that PCN capacity and access improvement plans. Here are some of the commitments that the our PCNs have signed up to and how they're going to help address and make primary care access even better. Work closer with our patient participation groups on getting survey responses. This is so important because getting positive feedback is as important as getting negative feedback. We need to know what should we be doing more of and not just what we shouldn't be doing. Peer review, really helpful. So if there are colleagues either on our patch or in Berkshire West or even in Bob who have pioneered on certain things, how we can learn from each other, that we don't need to make the same mistake twice or pick it up where someone has left off. And this area is one that I feel particularly passionate about, looking at that population health management, looking at segmentation, how we can use that type of intelligence in triaging and helping see the right patient. I've mentioned community pharmacy. And then here's another interesting part of our health workforce, our care coordinators that is now part of the primary care team to help support patients with long-term conditions. So if you have a long-term condition, you know that our management is not just seeing the GP, it is having the tests done beforehand, being acquainted with your numbers, then coming for an appointment to discuss it through with either your diabetic nurse or our long-term conditions nurse to formulate a plan and incorporate your views and how we can help you. Moving along, building capacity, do we have enough staff? looking at this slide, it seems that Berkshire West is actually not doing too badly on that front. And then this is an important slide too. This is our additional roles and reimbursement scheme, the ARRS scheme. This is the government has funded extra roles within primary care to help the GP practice fulfill its needs. Over the past few years, we've slowly increased our clinical workforce. There's clinical pharmacists now available, and I truly wonder how we managed without them before. Our pharmacists are able to do good medication reviews, spend extra time with you to make sure you understand your medication, and then importantly also, what medication can and should you stop taking? So stop medication is as important as adding on. Our pharmacists are now branching out into other fields like diabetes and blood pressure. We've got pharmacists, physiotherapists, that first contact that you don't need to be triaged through the GP. We have social prescribers that help with more social problems that patients may have that will affect their health. You know, if you've got difficulties in sorting out mold or getting your benefits, or the stresses of various social things, how that will affect your general health. We've got various other health staff and invaluable members of our team. Reducing bureaucracy. We can't do enough of this. Cutting through red tape, unnecessary paperwork, and so forth. Then other elements that affect access to primary care. I just want to stand still on a couple of points here. National campaigns. I think there's huge opportunity in this, and aligning that with our local comms and engagement teams. How do we get those positive messages out to everyone? As important to our patients as to what to expect within primary care, and importantly, what's available outside. And then intended changes on planning policy. This is having primary care and our ICB colleagues around the table when it's being discussed, new developments, because when populations are expanding, you need to look at it in context also of all the services that need to wrap around those patients or people. This is our last slide, and this is probably one that I am most involved in. I won't touch on everything, just the elements that I feel particularly passionate about. That first element of proactive care within primary care. This is, how do you live well with your long-term condition? So if you have diabetes or diabetes and COPD, how do we make sure that we arrive with a comprehensive care plan around you to make sure that you keep well? You know, around that multidisciplinary team will be someone from primary care, district nurses perhaps, community matrons, someone from social services. How can we help? Not everybody's in that situation, but for our patients who are housebound, that would be that MDT discussion that you can have, and needing the care coordinator to arrange for all of that. There's more and more diagnostics being worked up to be provided locally. And then lastly, this prevention and addressing inequalities. Absolutely important. This is more than health. We need all of our collective efforts to be able to do prevention and address health inequalities. Health needs to work with our local authorities, voluntary sectors, public health, because prevention is all of our business and addressing inequalities is our responsibility. To help shift this dial, we all need to work collectively, because it's the only way to make health and the NHS sustainable going forward. Thank you all. That's the end of the presentation. I'll try and unshare.
Right.
Easier said than done.
Thank you, Heike. That was a really, thank you very much. That was a very pretty clear and interesting report. I know members will have lots of questions. I just wanted to ask, first of all, when we give percentages of talk about surveys, I wondered whether you knew actually how many people have participated in the survey that you reported, because it was only half a dozen. It wouldn't mean much, but are we talking of hundreds? Do you know?
I'll put that to Helen Clark. For some reason, I've got 100 per month or something like that in mind. But Helen, do you have any clarity on that? How many surveys do they take per month?
So the friends and family numbers currently are quite low amongst a number of our practices following the reinstatement of the survey after COVID. So we're doing some work to increase the numbers on that, but that can be in the tens rather than the hundreds. The National Patient Survey tends to be a few hundred responses sent out per practice. But we can check the exact numbers for you if that would be helpful to give you a better idea. It's conducted each year between January and April, and it splits questions into questions, sort of general questions, and those targeted at patients who've recently attended practices. But happy to get a bit more background data on the West Berkshire results for you if that would be good.
Thank you for that, because obviously that's very relevant to the the information you give us. One other issue I had in mind was we saw on one of the slides the difference between all the different surgeries, and you talked about how peers were helping each other. And have we come up with any information about why we think some of these practices are so low? Some really stand out. Yeah, and if practices are helping each other, that demands time and resources. And I wonder, how that is handled and how that is monitored. But that seems to be really important, to actually share best practice.
Absolutely agree with you, Councillor Vickers. As I said, as a local GP, I can only give you my personal views on that. I think there's lots of matters to be taken into consideration, from being a more rural practice and to being more in a town city, the level of deprivation, the level of young families that you have. I think all of those things play a factor in how health and access is sought.
Yeah, but I think that's the sort of things we have in mind, but it's good to sort of hear your sort of comments on that and how they all help each other. Is that working? Can we see that that's happening already, or is it early days?
I think it is still early days. We've certainly learned a lot from COVID already, being thrusted in suddenly doing total telephone triage or being forced to do more online consultations. Certain practices, as you know, really embraced online consultations, and we can certainly take a lot of the learning from that, do's and don'ts. And so some practices have been a bit slower in rolling out online consultations. The new telephone system, we've certainly had really good feedback on that so far, and that it's made a big difference on how reception is doing their work, and also patients getting callbacks rather than waiting in line. So I think there is feedback, and I think we can only learn and work closer together. That is certainly the aim in addressing our common need.
Yeah. Can I just answer on that, Heike, as well? I think the fact that the capacity and access improvement plans have been developed at a PCN level is very much to encourage that kind of peer review and joint working between PCNs. Within PCNs, practices have sort of varying levels of resilience arrangement, which involve mutual support. And that's a sort of core part of business continuity planning, and also planning for surges in demand at peak periods. But I think the improvement plan process is more around the softer sort of peer review and sharing of best practice, and encouraging practices to do that as they bring in these new phone systems and methods of contact, such as online consultation.
Thank you very much for that. Councillor Gawley?
Hi, yeah, thank you, Chair. Thank you very much for your presentation. It's much appreciated, and it's good to see some kind of detail and data. I've got a couple of questions, really. I think the first big one that stands out to me is around the kind of empowering patients, which I think is fantastic. I think, it's a big part of everything we need to do is empowering residents more. But what I would say to a particular point here is around the role of the community pharmacy. One of the biggest kind of complaints that I've seen come across kind of my inbox is around the loss of pharmacies. So it seems a bit of a contradiction potentially that we've got community pharmacies closing where we are now expecting to put a higher demand of services upon them. I would just like to hear your kind of thoughts around how that's going to work together, and the challenges that we may face. Thank you.
Thank you, Councillor Gawley, and I'm with you on that completely. But I'm hoping that your collective powers as our councillors, we will help push that agenda through, because I think through the pharmacy needs assessment comes through the health and wellbeing boards. That assessment, are there enough pharmacies to be able to deal with the patient needs? So that is still within our gift to make that assessment, and we need to take that into consideration when we see pharmacies close. We also need to think of the benefits of online pharmacy being used. So if more people use online pharmacies, is that an opportunity for the physical pharmacies to actually be able to do more of these sort of health checks, health promotions, and so forth? But it's something that I feel that we should keep an eye on.
Ollie?
Yeah, just in follow up to that, do we provide the local pharmacies and the Health and Wellbeing Board the information and the kind of data behind how often these services take, how often they occur, how long they take, what kind of capacity those pharmacies would need, and also what funding they get? Do we provide that so they can build a capacity plan and effectively, I guess, a business plan to ensure that they can still operate?
Maybe Sarah I see she's got her hand up.
I think Sarah's got a hand up. Would you like to comment? Thank you.
Yes, yeah, hi, thanks. I'm Sarah. I'm the director for the ICB that covers West Berkshire, Reading and Wokingham. As Heike has mentioned, the Health and Wellbeing Board reviews the pharmaceutical needs. So that's based on demand and anticipated need of our pharmaceutical services locally. We've actually got a meeting next week to get together to have another review of that in light of the recent news that you will be aware of. And it's also really important to note that until recently, pharmaceutical services were commissioned directly by NHS England, whereas they've now been delegated to an ICB level. So we are working very closely with our colleagues across the patch in terms of what support we can offer directly to our local pharmacies to improve resilience and support, and in a way that makes sure that we not only maintain the current services we've got for our residents, but build on and develop those. Because, as you mentioned, communities often see the pharmacy as a place to go already, and that should become more and more so in terms of minor ailments, things that help us manage our own conditions independently and empower us as residents as well. So community pharmacy absolutely needs to be core to our approach to not only urgent same day need, but also how we manage our longer term conditions to live well with them.
Thank you for that. There is still work to be done on people understanding how they can use their pharmacies. You've got capacity, but I found that I can go and talk to the pharmacist now and get advice and get even small weak antibiotics over the counter, for something like eye infections, which never used to happen in the past. So there are changes, and I think we need to use our pharmacists more, and hopefully that will increase the capacity and make them, make the. Councillor McCrow, we've mentioned Health and Wellbeing Board. Have you got any comments in relation to the work Health and Wellbeing Board does and the reports and, about pharmacies and how we work with the community?
I was going to attend the meeting next week on this, and I think it's something I'm particularly concerned about because we've lost a pharmacy in my area, as well as the two now we're losing in Newbury. Something I am very concerned about, and I'm going to take part in that meeting next week.
Thank you very much. Councillor Foote.
Yeah, thank you very much, Chair. I have a question. You mentioned earlier, Heike, about the NHS app and the advantages of using that, and I'm concerned about the digitally challenged in our communities. That clearly it's going to be hard for them. And we've just been talking about community pharmacies and things like that. And I was just wondering. That I've got 2 points. First is that would there be any mileage in, for example, having tablets or anything like that? I'm not meaning pharmaceutical tablets, I'm meaning digital tablets at those community pharmacies so that, elderly or, as I say, digitally challenged members of the community can be guided. I know obviously confidentiality comes into the mix as well, but that's one point. Have you any comments on that?
Yes, thank you, Councillor. A couple of points on that. I think we should always be aware of digital inclusion, exclusion. I think if we get it right, and I know in our practice, we've certainly asked our patient participation group to see if they're able to help. There are certain courses, there's advertisements on how we can help people use the NHS app. It is firstly helping people, so people that feel that they're unable to use it, what help is out there for them in the first instance, because there is help available, and it is how do we promote that more. And then secondly, if the people that are able to use it more, that will free up time and telephone space for those that actually need to use it. So it is really a win-win. It is options and choices for our patients. Everybody doesn't have to use the NHS app, but those that can should use it more, and that we should try and help those who feel that they are not able to, but under no circumstance is anyone forced to use just one method.
Thank you. And if I may, I've just got a very quick follow-up. Councillor Vickers mentioned, the numbers that take part in the patient surveys and things. And in my experience, I think the only time I've sort of seen those advertisements is when I've actually gone to my doctor's surgery and sort of seen it on their information boards and that sort of thing. Again, would there be mileage in trying to work out a way of getting those patient surveys out into the community? So, for example, it's not always linked to when people visit a GP, but, for example, a library or something like that. Is there any mileage in making that more accessible so we can get a larger number of participants taking part in these very important data surveys? Thanks.
I think Helen has a comment here. Do you want to answer that?
Yeah, so I just wanted to say, so the National Patient Survey is, as it sounds, administered nationally by Ipsos Mori, and it's a postal survey sent to a random selection of patients. So there's probably not so much we can do around that, although we can have supplementary information within practices for patients who have received that survey. Where we do work closely with practices is with regard to local surveys that many undertake in conjunction with their patient participation groups, and obviously Health Watch also having involvement in that area as well. So absolutely, where there's local surveying going on, I think that is an area we can work together to think about how we can get the messaging out there to really encourage people to participate and provide feedback through those means.
Thank you. Yeah, communication is really important. There's been changes in my surgery which I've not been aware of, and I think I mentioned it to somebody I know who's on my surgery's patient participation group, and she said, "Oh, well, why don't you read the newsletter?" I've never read the newsletter. I believe there's a newsletter online. Maybe all surgeries have that, and I'm sorry, haven't been accessing that. So maybe I should, but maybe, as Councillor Foote has pointed out, you need just a few copies in a surgery, or if there's a change being made, don't just rely on people seeing it online. Put a poster up, put one big poster up. I never see any posters in my surgeries. They just want to put pictures on their walls. I'd like a useful poster telling me what's changed, and this is where a lot of patients would look. They might see that, or making sure that, you know, when people are making appointments, that maybe it's an add-on, that the receptionist, you know, add comments. Did you know about the changes? You know, have a little note by the side of their desk or something. Yes, Sarah, you want to say something?
Yes, thank you, Chair. I think I'd just also add to that, this is an area that we think we could probably work together on, using your, both as councillors and local authorities as organisations, reach out to your own residents as well. So I know our comms and engagement equivalents are in conversation about how we better tie up, so that when we do need to get messages out to the public or suggestions of please make sure you fill in these surveys when you go to your GP practice, we can use the routes that are already really well established out to our residents, rather than relying on them following a Twitter account from the ICB that I think probably not that many people will follow, because they're more likely to follow their local councillor or their local council or their local community centre. So we're working on that as well.
For that, Councillor Gawley.
Yeah, I've just got kind of one quick question really around the kind of upskilling and kind of training of receptionists to offer more of a care navigator role, which I think is interesting. And one of the pieces of feedback that I always hear is from residents is, why is the reception asking me 1,000 questions? Why are they blocking me from speaking to a care professional, et cetera, et cetera? That's how it's perceived. So I suppose my question really is, what are surgeries doing to empower receptionists or reposition that role? And how is that communicated to the wider public, so the wider public actually know why they're asking those questions and what that role actually entails, to perhaps try and cut down some of that friction or perception challenge?
Thank you, Councillor Gawley. Yes, I can tell you about some progress and certainly opportunities for doing more. Care navigation is a wonderful thing to work towards, you know, that you don't have to be a receptionist firstly. So from a job satisfaction perspective, don't have to be a receptionist all of your life. You can upskill and feel better and know that you're helping the patients. Some of our receptionists have been working many years, more than I've been working as a GP. So there's certainly a trust element, and that's a lot of what GP is about. That care navigation is important because it will also help in the wait times for who's the most appropriate person to be seen. And it has certainly improved over the years. COVID, yet again, thrusted us into total triage, where we were forced to speak more and not just be seen. But the benefit that also came from that is messages were sent out either through text, on the practice websites, on the front doors. Why are receptionists asking more? Even when you answer when you call in, speaking to on the phone, the voice might say, our receptionist may ask you a few questions. This is to help directly to the most appropriate clinician. So yet again, like I pointed out, you don't no longer need to see a doctor to get a physio appointment. So that's one of the things that our physios are able to help. I've got a knee pain, an elbow pain, it was an injury, whenever. Directly, I can book you in directly with the physio, instead of a GP appointment within 2 weeks and then maybe another 6 weeks following that to see the physio. So the challenge that I put to us all, how do we get that message out even more? And that's why, you know, on that slide, I stood still on the comms and engagement, because I feel we could do more, and that will help access.
If I may add to that as well, I think we touched on this at the last meeting as well, about public understanding of the additional roles within practices as well. So we've mentioned physios, pharmacists, paramedics, nurses, and we know that there's more we need to do to inform and reassure our residents about the appropriateness of different clinicians within general practice, and it's not all just it's not always a GP that they'll need to see. And so Health Watch are very helpfully doing a project with us at the moment to look into exactly that, so that informs how we go forward in terms of engaging and informing our public around and reassuring around the various roles that are available in general practice, and why that is actually a really, really good thing.
Thank you. Can I ask, as triage, does it always have to be by phone? I used to sort of find it very useful to have consultations with the GP sort of online, sending a message and getting something back. But I'm told that's difficult because you can't triage that way. Can triage only be on the phone?
No, Councillor Vickers, you're absolutely right. And that using online consultation, and there's sort of different degrees of online consultation where it might point you in a direction of lots of questions, and already then through those questions be able to filter you to what is the most appropriate or who's the most appropriate. Some online consultations is sort of ask my GP, and it's a free text ability. And each practice, and this comes from the learning, or, as I said, my personal experience, the learning from other practices who have done more online consultations. What is the most efficient process that can be put in place within a practice so it gets to the right clinician? Some of the other requests might be a simple sick note, or can I have more medication? And that more medication will then filter directly to our pharmacist. So that there is certainly, they might not call it triage, but filtering in the right direction.
Thank you very much for that. I mean, another comment, a question I'd like to ask. We hear that some practices are moving to 11 o'clock calls for routine appointments rather than 8 a.m. Is that something that's happening in practices, and has it been successful? Is it likely to be rolled out more?
Yes, I can't vouch for it being rolled out more, but hopefully with the success, if it is a success, then we be able to share the good practice. The big idea behind it obviously is to stop that please call back 8 o'clock in the morning and being in the queue. So it filters immediately. Do I need an on the day appointment for today, or can I have an appointment within 2 weeks? And so that appointment within 2 weeks would then be encouraged to be the 11 o'clock call. So hopefully making the access for the people that need on the day at 8 o'clock slightly easier.
Right. I mean, there's an awful lot of work going on. I can see everybody's doing their best to try and make the most of results.
Oh, absolutely.
You mentioned in your report about outreach and community venues, about trying to get to people, you know, I mean, the work of getting people to take charge of their own health and all that sort of thing could best be sort of, progressed in that way, but also reaching different people and spreading health messages. Is there any examples of that? Is that happening much in any part of the district?
So there's a proposal that we're working through at the moment for a service that's going to be across the 3 local authority areas. So that includes West Berkshire, for a wellness outreach service that is going to be delivering health checks and wider wellbeing conversations in different venues, targeting areas that are most in need in terms of inequalities of access. So we're just working through the final stages of that at the moment. It's being discussed through our, so it's a joint proposal with the local authorities and wider colleagues, and it's being managed through the locality integration boards that feed into the Health and Wellbeing Board. So really excited about that. That's some ICB funding that we've dedicated and allocated to inequalities and prevention initiatives, of which we thought this community wellness outreach service would be a really excellent place to start.
Thank you very much for that. One note I have here just to raise is that we've had feedback from the Learning Disability Partnership Board, and they're concerned over whether the surgeries would be prepared to offer reasonable adjustments where possible with someone with complex needs and anxiety. With all these different changes, obviously, they're going to find it really difficult to navigate. And is that something the practices are taking into mind to assist them?
Thank you, Councillor. Yes, that is something that we're taking into consideration. That alongside our patients with learning disability and also SMI, even our patients with dementia. So all sorts of categories of inequalities and more difficulty in certain set ways. The clinical lead for LD and mental health made some training available to practices as to how do we help practices or patients a little better? How do we give health checks and make sure that people are not left or feel left or needing to navigate a difficult process? So there is certainly training and willingness in our patch to do that well.
Thank you. That's good. That's reassuring. Councillor Jeffrey.
Thank you. Can I just ask the specific question? Since the 8 a.m. idea that 8 a.m. is a call to have a doctor's appointment that day, and the 11 o'clock call is to arrange one within a couple of weeks, has that had any visible effect on what has been happening when you're making the appointments?
Helen, do you want to go, and then I'll give our personal experience on that one.
Yeah, that's fine. I mean, I was just going to say that isn't necessarily something that's being implemented across all practices. That is the sort of innovation that the practices and PCNs are making as part of the capacity and access improvement plans to sort of continually review and adjust their contact arrangements. So I think it falls into that category. We absolutely will be talking to practices that have made that change to understand whether it's had a positive impact and what the patient reported experience of that arrangement is. But Heike, do you want to come in more specifically?
Yes, and as I said, Councillor Jeffrey, speaking of personal experience, our patients seem to be appreciative of it. Yet again, change happens, it's a little bit tricky in the beginning to say call back at 11. But once that message came out and it was clearly communicated on the practice website, on the door, on the telephone, so the patients can know what to expect, certainly the people going through that route who come through the door and manage to sit in front of me, or I speak to them on the phone, are certainly finding it to be an easier approach, access, and shorter wait.
Thank you. And the second point I just wanted to flag up was, and I now can't remember exactly where it was, but it makes reference to having you live well with your new diagnosis. How does that work, making somebody live well with their diagnosis, please?
So if I could give an example, so I'm going to give you with two hats on, one with my long-term conditions as my ICB role, and then my role as a GP. Our chronic conditions need to be seen as something not that you carry and is a burden, but it can be well controlled, because a well-controlled long-term condition, whether that is high blood pressure or diabetes, will leave you feeling better. If you have diabetes and we say you will benefit from a few lifestyle changes as well as medication, by losing the weight, you feel healthier, sort of a new zest of life. Your numbers are better, and we might even be able to reduce your medication to keep the same level of fitness. So that goes with, because you've got diabetes, so me as a GP, because you've got diabetes or heart disease or you've had a stroke, that doesn't mean that you can't enjoy life anymore, because life is there for living. You should still be able to, if you feel well enough, to enjoy the grandkids, go on holidays. That is the type of thing that we hope that people will strive for. So it is not like you're condemned with your condition and this is your lot. Rather, how do we control it and how can you live well with it?
Thank you very much for that. That was very well explained. And if anybody was listening, I think with a long-term condition, I think I would hope that would be very encouraging. That it's just a case of sort of getting to grips with and you knowing that there's help out there. Just one final point from me, and we know the GP contract is changing, and I wonder if you have any comments on that. I mean, the public won't be necessarily aware of this. Are they going to be aware of it? Are there going to be things that will be sorted as an interface with the public? So, what will be the impact locally? And workforce issues and your resources, are there any challenges you can see facing this change?
Helen, did you want to take that one?
Yes, so GP contracts, as people may be aware, are nationally negotiated. So there is an ongoing negotiation process around what the contract will look like for next year and for future years. I'm afraid we don't have very much detail on that at the moment. I'm sure once it comes through, there will be information in the press, and obviously we'll be thinking about what information is helpful for us to share with patients. But at this point, there aren't any detail of what those changes might look like. Having said that, I think it's reasonable to assume that certain aspects of the current contracting arrangements will continue, perhaps in a slightly tweaked form, but nonetheless still continue to be really important. And those will include things like the diversified workforce model, which Heike has already described, and the additional funding for staffing in primary care that has been brought in through the current contract, we do know will remain in some form. I think there'll be a continued emphasis on access, which is absolutely top of everybody's agenda at the moment, and on encouraging practices to work together, to collaborate around key areas, and to really support patients across all types of care, both in terms of same-day needs, long-term conditions, and also taking preventative approaches to health. So expecting quite a degree of continuity, but the exact details are still to come through that national negotiation process.
Thank you very, very much for that. Members, do you have any more questions? And any more points to raise? Well, I think I'll just thank everybody for the presentation and for the questions. Thank you for your hard work. And we look forward to hearing more in the future about how things are progressing. So thank you, Heike, Sarah and Helen. Thank you.
Thank you.
Bye-bye. You are welcome to stay, but I'll appreciate it if you need to go. I think Sarah's probably staying. I don't know. Thank you. Thank you. Bye-bye. Right. So just to say that there are no recommendations associated with the report. So members are asked to note the report and at some stage consider if you wish to see any further scrutiny of the work or matters raised in the report, putting it into a future work programme. I would have thought we're going to be wanting to have an update. I don't know, will that be 6 monthly, yearly, or what? No, depending.
I think an annual update would probably be suitable.
Okay, just to give, because it takes a while, doesn't it, to make changes? Yeah. Councillor Foote.
Yeah, thank you. Could I suggest that the pharmacy situation is one we do need to keep a very close eye on, and that maybe a 6-month update, even if it was just on the pharmacy situation for us locally and nationally, would be really important and helpful. Thanks.
They're definitely. Well, will that be coming to Health and Wellbeing Board again, or that I'm not quite sure what the relationship is? Yeah. Yeah. Yes.
There's a pharmacy needs assessment, which I think does come to Health and Wellbeing Board. So as long as we tie that in terms of timing, then this board can see it as well. Absolutely.
Thank you. So just, yes, it's a very important one, because I mean, it's we don't have powers, but surely we can sort of highlight the importance and the anxieties and the concerns and try and influence what's going on. Yes, Chairman.
I've got involved in looking at the issue of the pharmacy services directly, because various things were happening in Thatcham that were particularly difficult during the spring and the summer. And as a direct result, I probably know more about it than I would ever dreamt that I would know about pharmacies and pharmacy services. One of the things which is happening is that for what it was formerly the Lloyd's pharmacy is, I don't know if it's literally ceasing to exist, but different Lloyd's pharmacies are going off to other pharmacies at the moment. And it is proving pretty difficult, because they're literally not being allowed to bring in supplies to the individual pharmacy shops unless and until the order's there, because they are going through the process of being transferred. It's not even that Lloyd's is going to Boots or anything that straightforward, but some are going here and some are going there, and it is a pretty confusing picture. I would think that that is one where it would be very useful if we could have a specific piece of work on it, or a particular monitoring brief that we can keep on what is happening, to see what is happening with the pharmacy services.
Thank you very much, Councillor Jeffrey. Certainly we'll consider that. Thank you. We'll move on to item 7, our report on continuing healthcare. And we have, do we have Liz Hodgkinson? Yes, we have Liz Hodgkinson and Nikki Cartwright here to present the report. So thank you very much, and over to you.
Thank you, Chair. And thank you for inviting us to update you on where we've got to with our CHC transformation. I won't share my screen just because my bandwidth is not always brilliant. However, my report actually starts on page 68 of the pack of agenda papers. And I'm just going to talk you through a summary as to how we've got to where we are, what the recommendations were from our consultants who came in and worked with us, the impact and the benefits of the changes in the transformation programme that we are implementing, and then just a summary of our next steps. So just some background, somebody appended the peer review that was undertaken in July 2020. So that gives you the context to some of the areas of improvement that were highlighted, not just for the ICB, but it was for all the 5 local authorities and the ICB. So it was a system commentary that we received and areas for improvement. In particular, it illustrated the need for better joint working relationships to ensure that we are effectively delivering for the people whom we serve. We had already got in train and developed the procurement of a transformation plan, but this was helpful because it gave us quite a lot of meat to help shape what that plan was going to look like. And we went out and procured some external consultancy and set up our transformation programme. It was last September. And we've just come to the end of that year's programme with those consultants now. And again, I'll talk about the next steps at the end of the presentation. We set up a transformation board, and we are really delighted that all 5 of our local authorities were members of that board. And I see Fiona's here. One of Fiona's predecessors was a member of the board as well. So we had a broad range of stakeholders in that programme. And the external consultancy, they did what I would call a very sort of detailed review of all our systems and processes and our staffing, and then out of that developed a set of recommendations which I'll talk you through in a moment. They were approved both by the ICB but also supported by the Transformation Board. And as I said, that was a partnership board. And just worth noting that we had 2 continuing healthcare teams who were hosted, as we call it, by Oxford Health Foundation Trust. They covered Oxfordshire and Buckinghamshire. And we moved those back into the ICB's direct management in July this year. So we had a 2P process to go through for over 100 staff. So that's taken time. But I have to say, I think it's given us a fantastic opportunity. And when I talk about some of our recommendations about working at scale, you'll see how that helps us deliver that much more easily. But it was no small feat getting those staff transferred safely and back into the ICB. So, but pleased they're here. If I move on to the recommendations, they're very much focused around delivery. So clarity that we need to support the core functions and processes of CHC. And I think if I reflect on CHC over the last sort of 5 to 10 years, there have been a lot of new things that have come along and just been added into CHC but have never been properly resourced. And when you had 3 separate teams, that made those functions quite fragile. So, for example, personal health budgets was something that is a requirement for the ICB, but if you're doing that in 3 places, that's much harder to do than if you just do that as a single function. We also, it was recommended and we agreed that we would reduce our teams from 3 to 2, and you'll see that the Berkshire West team and the Buckinghamshire teams will merge and will be a single manager across those 2 teams. They will keep their locality focus, so we won't lose that Berkshire West assessment and case management team, but there will be a single manager, and that will help again with that resilience, because those are Buckinghamshire and Berkshire West, we're both quite small teams. So again, trying to work at scale, do it once, and make sure that we are able to support the functions that are required of us. We've agreed a governance structure that was clear and unambiguous. As I said, we had our transformation programme. We've now moved that into a programme board. Again, the 5 local authorities are members of that. And I think we've got our first meeting at the end of September. So that's our external governance. And then we have some internal governance, which is around our business as usual. Which again, that's important that we are able to develop that consistency of approach. See how we're performing, looking at our sort of staff well-being, our sickness, etc. Just again, as I said, it's just really it's that consistency that's so important. Our future structure, so our two teams which have come down from 3. And then also we have some centralised functions, mean that we've got that visibility from top to bottom, so we can see all those end-to-end processes and manage a number of them across the ICB rather than just a place. And again, that really just the last recommendation was around the staffing structure. We're just in the process of going into consultation with staff on that, which I will touch on at the end. But again, that is about ensuring that we can deliver an effective service to patients and their carers. And finally, and I said this in other places, I'd make no apologies that this is an 18-month to 2-year programme. It's not a quick fix. This is a large group of staff, and it's a really important statutory function that we get right. So we are expecting that, it will be 2025 by the time we would see the benefits of all of our programme realised. However, that doesn't mean to say that once we get to the end of that programme, we suddenly stop. We need to continue to iterate and improve whatever we're doing. And some of that is about our quality assurance. And I'll touch on our sort of patient experience work that we're doing sort of later on in the presentation. But again, all feeding into our quality improvement programme. And we agreed that we would implement immediately and sort of crack on with it really. There's a sense of urgency. We know that our stakeholders are keen to see the changes realised and see how that new way of working fits together. So in terms of the impact of transformation, we want to ensure that we meet the requirements of the national framework and any associated legislation. And that impact, we want to ensure there's equity and eligibility across the ICB. I know within Berkshire West, and I think we've all spent time discussing this, about the issue of why is Berkshire West one of the low, or probably almost the lowest in the country in terms of eligibility. And there have been a number of reviews over the years to look into that. And I've just asked the North NHS South East regional team to come in and have another review with us of that, so that we can see if there's anything that is going wrong. That's never come to light so far, but it's worth another look, and I hope that gives you some assurance that we are continually looking at that. We want to take advantages of our scale opportunities, as I've touched on already. So in particular, there is some commissioning that we can do across the ICB, and some of those really complex and specialist care packages that we need to commission. So you don't have many of those, you don't have many people in a year who need those. But if we can take advantage and commission those at scale, then that gives us a much better result in terms of the cost of the packages, but also that quality and oversight. We want to improve our patient experience, and one of our task and finish groups was a patient experience group, and we'll be launching our questionnaire, which will go to everybody who has been in touch with our CHC service, whether they have been deemed eligible or not, to ask for their experience of our service. And then we'll use that output to inform any quality improvements that we can make. We want to ensure that we've got much better oversight of performance improvement, and I think I've probably talked about that at length, and again, it's about ensuring our patient experience is a good one. CHC is a really tough one for people, and you may have heard me say this before, but it is probably the only time in your NHS journey where you're told yes or no. We're told that NHS is free at the point of delivery, except when you go for CHC. And when people are found ineligible, that's really difficult for them. And that kind of goes against what we as a country are almost led to believe. So it's very important to us that we can make that as good as possible. And again, we want to reduce our variation, and that touches on my first point on this area about ensuring there's equity. And the regional team are going to be coming in to have a look at that for us. And then just some of the benefits, and forgive me, some of this is repetition, but I just think it's really important just to be clear about what we think those benefits are and what we are expecting to realise. So that bigger geography. So for example, if you think about children's continuing care, in Berkshire West, we have one children's nurse, and the same in Buckinghamshire, slightly better resourced in Oxfordshire. But if that one member of staff is on leave, it's very difficult then to ensure that you've got effective cover. So we're going to have a single team under a single manager. They'll still have that locality focus, because it's really important to have those local relationships and for them to understand the local market that they're working within. But it does mean that we can really ensure that if somebody's away or somebody's off sick, that we've then got that cover for them, so we haven't then got that sort of dip in service. We want, and this is sort of similar really, more flexibility in managing our CHC service and staff and the budgets. So we've centralised a number of our business management functions. Again, that's a more efficient way of working, but also gives us that resilience. Really keen to reset our relationships with our 3 Berkshire West local authorities in particular, and improve our collaboration. I think if you talk to staff on the ground, there has been an improvement, but there's always more that we can do. And really just looking at being really clear about what that change is going to deliver. It's not just we carry on doing it as we've always done, but let's take the opportunity to really shake things up. And then finally, just some next steps. As I said already, we've got some revised governance in place now. All 5 local authorities are members of that, which is brilliant. We've got a project manager who's been appointed to support the delivery of our transformation plan, and we've got that with key milestones. We've signed off in the ICB our new staffing structure, and we'll be commencing our 30-day consultation in September. And we expect that interviews for new posts will commence in November. Not underestimating how big that change is, although we're talking about 120 staff in total. Not all of them will be affected in terms of posts, having to apply for new posts, but some people will be, and we want to really make sure that we do that in a thoughtful and supportive way, but equally recognising how important it is to help us with our sort of changed model of delivery. And we'll need to think carefully about how we bring together the Buckinghamshire and the Berkshire West teams, because what we don't want to do is throw out what's good. What we want to do is bring those teams together and build on the best that each of them is offering at the moment. And then finally, but most importantly, is getting our patient survey, experience survey up and running as a regular business as usual activity, so that again we can use that to continually improve our offer. So that's it in conclusion. I'm really happy to take questions, and Liz is here. Liz is the Deputy Director for CHC across the ICB, and also was the national policy lead for continuing healthcare at NHS England. So very well versed in CHC in a good way. So thank you very much for listening.
Thank you for that. Thank you for that presentation. I mean, obviously we all appreciate you've got a difficult job to do. I mean, it is quite disturbing reading the reports about Berkshire Healthcare and how, you know, how it's not been doing very well, but it's also very reassuring that you're, you know, opened yourself to peer review and taking on board the help and support that's available. So I just wanted to ask, this is a difficult subject, which many people don't even understand what continuing healthcare is, or should we be saying all age continuing healthcare now? Could you give us a definition of
over to Liz.
healthcare?
Yeah, Liz, go for it.
I would say that's the I don't know, $40 million, probably even more question, because I think even when you speak to the policy team in the Department of Health about what is and what isn't, it is a grey area, because even the Secretary of State that defined, well, it's not even defined, primary health need, which determines whether you are eligible or not for continuing healthcare, it is a grey area. So there isn't a strict answer, and the framework, as you'll have seen, is a number of pages and then still relies on a professional opinion. I think all I would say is that it is those really complex healthcare issues, but ultimately that we incorporate social care within that. I don't know if that helps or hinders, but going back to your question of all age continuing care, should we be calling it that? I would say very much as a policy person, continuing healthcare is very clearly the adult aspect, and children and young people's continuing care is for the younger people. All age continuing care is just an umbrella term that covers the wider service as a whole.
Thank you for that. Not simple. Before we move on to questions from our members, I'd like Paul Coe to make some comments here. Oh, thank you, Paul.
Thank you, Chair. Yeah, well, certainly I recognise what Nikki and Liz have said. That I do have some optimism. I think the merging of the Buckinghamshire and Berkshire West provision gives us a good opportunity to, as I think Nikki said, kind of import good practice rather than anything else. I guess the mixed message that I took from Nikki's presentation, which I can completely understand, was one about timing. So I heard a few things, Nikki. I heard sense of urgency. I heard difficult and detailed 2025, and people on the ground now saying that things are maybe improving. I guess what we'd want to see, certainly I think the people of West Berkshire would want to see positive changes in as timely a fashion as is possible. I'm not sure, I don't quite share Nikki's optimism in terms of, I think if you asked staff on the ground today, they would probably not see a marked difference, and I can understand why. I suppose the test will be, can we start to see positive change before the full delivery of the full programme? Because I think it would be frustrating if we were, deep into 2024 and not feeling that things were changing or had changed. So I suppose my suggestion to this board is that keeping this programme in sight is probably important. I think there's a question about, well, when would be useful? Because I get why some of these benefits won't be realised for some time yet. But I do also think that, as I say, 2025 feels like it's a long way away. Chair.
Thank you very much for that, Paul. Councillor Gawley?
Yes, thank you for your report. And I think I would share Martha's concern that the peer review is somewhat bleak reading and difficult in places. And I must admit, I lost count of the number of times I saw the word lack of mentioned, especially in the Berkshire West portion, which is very concerning. moving over to the report that the presentation slides you've just given, I think my question really is around the recommendations. So just so I understand if I'm reading it correctly. So all of the recommendations start to agree and then have what I perceive as an action to follow that. So is the recommendations there just to agree, or is it to agree and deliver that action or that recommendation?
They've all been agreed and they're all going to be part of the delivery of the new way of working.
Thank you. And my second kind of follow-up, if that's okay, is the RAG rating that's attached to that recommendation. So they're all lit green, which is a positive thing, I think. Is that green that they are on track, they are within the agreed actions and time limits, or is it that they are complete?
The greenness is relative to the fact that they've been agreed and they are part of the delivery of the, as I said, the future delivery of the service. So if we take, for example, it was recommended that we'd go from 3 to 2 teams. Tick, yes, that's been agreed, signed off, and is part of the staffing structure change that we're implementing. We're doing informal consultation at the moment, and we'll move into formal consultation at the end of September.
Just quickly, just one more question to follow that up. Is it possible to get the next level down of actions that underpin those recommendations and what the status is with those, please? Is that something?
That would be part of our detailed project plan.
And then that would be useful to bring back to this committee, I think. Thank you.
Thank you, Councillor Gawley. Councillor Foote.
Yeah, thank you very much, Chair. I would echo probably everybody in this room. It is a very disappointing peer review, and you'll have to excuse me because I'm a relatively new, well, I am a very new district councillor. And one thing that I find intriguing, looking at this almost as a layperson with a fresh pair of eyes, is the structure of Berkshire West. Because we've got Oxfordshire obviously seem to have led the way. Buckinghamshire have got an outstanding peer review, and then we've got Berkshire West, which is made up of 3 unitary authorities. Now, running through the peer review is a constant theme of poor communication, lack of leadership, and I personally don't think this necessarily is a personal thing leveled at individuals as such, but the fact that it's just so blooming difficult when you've got 3 unitary authorities all trying to do the same thing, whereas Buckinghamshire and Oxfordshire don't have that problem. That's one aspect. We are where we are, I suppose, and I would like to ask Nikki, you said, I think in your presentation, that we were linking up with Buckinghamshire. And I think you mentioned, I think I heard it correctly, that it's because we're about similar size. I'd like you to sort of just elaborate on that, because one of the points that I've been thinking about is if we were to consider a restructure, would we in West Berkshire wouldn't it be an idea for us to link in with Oxfordshire, and the other 2, Reading and Wokingham, link in with Buckinghamshire, from a geographical point of view. So I appreciate it's a very basic question and it might take a lot of time to answer, but perhaps you could just enlighten us a little bit on that, please, Nikki. Thank you.
So the population size is not the issue. It was the size of the teams that drove the, in particular, drew that recommendation that we should merge those. Also, Buckinghamshire was, I think, came out very well in the peer review. There are a number of areas that we could capitalise on there. Oxfordshire is a much bigger team, is functioning well. Some changes that we obviously will need to make there as well. And there's changes that need to be made across them all. But it was based on that. I mean, that's an interesting point. But that's kind of where we are now. Yeah, so Sarah's got her hand up.
I think just on the particular point around the team structure, I think it's something that we're going to be continuing to review. So we knew that continuing with the 3 separate teams wasn't working because of the reasons that Nikki's very clearly outlined and the ability to cross cover and add sustainability. This was one step forward, and we'll continue to review it as best practice when we make any changes. And if an alternative arrangement is felt to be stronger, then we'll have to be considering that as well as we go forward, as we would do with any of our services. I think the broader question around the construct of Oxfordshire, Buckinghamshire, and then Berkshire West is one that went through an awful lot of discussion in the latest restructure of the health landscape, and I think it could have landed in a number of ways. And actually, this is the construct that was landed. It's 3 separate, what we call places across the BOB footprint, of which Berkshire West covering the 3 unitary authorities. So it does make it a bit complicated at times, and I can't see Paul on screen, but he may be smiling because we're working through this a lot in terms of the conversations of how to get the best out of it, to make sure that where we can do things consistently across the 3 we do, but also we don't lose sight of the fact that we've got 3 very distinct local authorities with populations that have differing needs, and there's a lot of differences between Woking and Reading and West Berkshire that we can't lose sight of. So I would just give you some assurance that it is a continuing conversation and something that we always have on the radar to make sure that we're not treating it as one homogenized geographical area, and that we're continuing to respect the differences of the 3 local authorities.
Thank you very much.
Thank you for that, and thank you for raising that, Councillor Foote. I mean, it all gets more and more complex and difficult, doesn't it? The more you think about it. I've got a specific question here about referrals and conversion rate. I think we're told some of the report that the referrals are being made on target for 28 days, but they're not being converted. So I wonder whether you can tell us what the current conversion rate is in BOB compared to England, and what the situation is in West Berkshire.
Chair, I would have to send that information to you after this meeting. I just haven't brought it with me, so apologies for that. In terms of the 28 days, that's the timescale that you have you receive the CHC checklist, and you have 28 days in which time to carry out the assessment and then reach the point where the decision is made whether the person is eligible or not. So in Berkshire West, we're doing very well on that. We've got backlogs in the other areas which we're currently addressing, and I will send you the performance information when we've finished.
All right, thank you. I was also wondering about advocacy. I mean, do we think that as many people who are eligible for continuing healthcare are getting it? You know, some people struggle. They might make one application and then maybe they should come back and make another one if they're refused. I mean, this happens. Is there some advocacy out there and assistance for them?
Well, the application is usually made by a healthcare or social care professional. So the individual themselves don't have to do the application themselves, because it's a technical piece of work that you've got to do. I mean, there are advocacy groups. I don't know how often they're used. When an MDT is held, there is an opportunity, patients can, or their carers can be invited to that. And I guess that would be the point perhaps where people might want some advocacy support. I mean, I can certainly take that away and look at that. It's a really interesting point that you've made.
I mean, obviously, equality of access is an issue as well. Is there anything you're doing there to ensure that?
Well, that's one of the reasons why I'm really keen the regional team come back in and have another look at this. We know that we think it might be our checklists, because we're not getting enough checklists. Checklists are what drive the numbers through into eligibility, and you need that constant flow. And we think that we maybe not be getting enough checklists. But the regional team will help us on that. And then it's about, I've already had conversations with Berkshire Healthcare about the community nursing service, and then they can put checklists in. So that's part of the work that we'll be doing in the future.
Thank you. I mean, apologies if I missed this, but you are gathering feedback on the process as you go along, just to sort of gauge.
That's our patient experience survey that's has been agreed through one of our task and finish groups, and which we are going to be implementing immediately. So you're sort of taking Paul's point about why is it taking until 2024? It's not all taking until 2024. There is a sense of urgency around something like the patient experience, because that will help to drive further improvements. So we're going to be implementing that now. In terms of the staffing structure, it's 120 staff we need to consult with. So that will take time, and it will take time to feed that through all of those staff once we've completed the consultation, got people into their new posts, settled people in, done the work with the Berkshire West and Buckinghamshire teams to pull them together. So, there's some things that we're doing immediately, but there's other things that we're not going to rush. We're going to do them properly, and that will take time.
Are you aware of any sort of short-term improvements, anything that's happened since you started this process, or is it really too early? Can you say?
I think we have a much better oversight of performance across all three teams now. We've got, as I said, we've had our patient experience group. We've got a plan around, and this, we have policies and procedures that all need to be brought together. We know what they are. We have an ordered list of when we can start to approach those. We've got the joint funding pilot. Well, that's not an integral part of CHC. That's something that's been worked through in Berkshire West, which was something that we've sort of run alongside this transformation programme. We've got much better oversight of our spend now that all three of the teams are within our ICB management. We didn't have that before. So we can start to see, where are we leaking money? And with some of those very high cost packages, how can we ensure that the quality oversight is in there?
Well, thank you very, very much for that. Members, have you got any more questions? Yes.
Yeah, just one last one for me. Obviously, are you confident that everyone in Berkshire West who is eligible for CHC funding is in receipt of it?
I don't think I could answer that for any of the areas, because I couldn't answer it equally. That am I confident that everybody who's in receipt of CHC should be in receipt of CHC? It's just that's a really tricky one, and that's why I'm really keen that the regional team come in and work with us again to look at is there anything we can do to improve our eligibility rates? Because if people aren't receiving CHC and they are eligible for it, then that's wrong. Equally, if people are ineligible and they're receiving CHC, that's also wrong, because it's denying care to people who need it. And that's what we need to get to the bottom of.
And just quickly to follow up on that point, if it's okay, Chair, as this transformation programme happens, then will there be a case of going back to re-review some of the cases that have come before you that have perhaps been declined, and vice versa, reviewing those cases where it has been granted as things improve and processes become more robust?
No, people who are in receipt of CHC should be reviewed. That goes without saying. And sometimes people's needs have changed and they move out of CHC. It's a really difficult conversation to have, and very difficult for the individual. But equally, if somebody is no longer eligible for CHC, then they shouldn't be receiving it. And that might sound very cold and hard-hearted, but that's kind of a fact of life. But there is no plan to go back and retrospectively review people and say, well, you're now out of funding. It is part of our ongoing case management and our sort of best practice that people are reviewed.
I guess for me, it's that what concerns me is that gap between what the national average and the rest of people are getting versus what the Berkshire West kind of success rate is, which leads me to believe that there is potentially people missing out. So it's, that does make me feel uncomfortable if you folks aren't going to go back and review some of these cases.
If I could just add to that as well, there always, if it's at all reassuring, there always has been and there continues to be a process of review and appeal. So if someone goes through the CHC assessment process, there is a national appeal process if they disagree with the decision that they've reached, and that's always been available to our residents throughout. So that obviously will continue, and we make sure that people who go through this process understand about the process for appealing any decisions. I think that as Nikki's mentioned, making sure that we're capturing everybody is vital, and it's quite unusual for someone to go from having absolutely no interaction with either social care or healthcare services to then suddenly being eligible for CHC. So as Nikki said, it's working with our colleagues at Berkshire Healthcare who are providing care in the community, and with our social care colleagues to make sure that we are getting as many referrals, all the appropriate referrals in that we should be.
Just a quickie, have we seen many appeals in Berkshire West?
We don't have many, and those that we do have are upheld, and our decisions are viable. You know, they are upheld. So we are, again, I can make sure that's shared in the report that I will send to you.
It would be good to get that data again versus the national average and the Bob as well, perhaps, so we can compare. Thank you.
Councillor Gawley. Councillor Ford.
Yeah, thank you. It sort of follows on from what Stuart was saying. It's reminded me of something that was in the peer review. When you looked at Buckinghamshire, when one looked at their data, it highlighted the fact that they were particularly good at putting the patient and the patient's relatives, I guess, at the forefront of what they were doing. And then when you compared it to Berkshire West, we weren't in the same league as far as that was concerned. Now, obviously, we're in this process of review and reassessment and reorganizing based on that peer review that we've just had. Can you reassure us that the patient and the, or I should say the individual and their families are front and center in your handling of the cases, rather than looking at it perhaps purely from a financial point of view and how it's going to impact on our financial situation? Thank you.
Yes, so one of the reasons, as I was saying earlier on, we'll be merging those two teams, and the expectation is that we will keep what's good in each team, but equally what we think isn't working will be disregarded. However, I can assure you that there is no financial I'm trying to think of the right word, that when people are assessed and when we have the MDTs and the meeting where eligibility is decided, the clinical staff do not have in their heads about the financial impact. We're absolutely clear about that with our teams. That is not to be taken into account. And, you know, if I shared our financial information with you, you will see that we have massive overspends on our CHC budgets because that is not part of the thinking.
Thank you.
And I can assure you of that. I would be very, very disappointed if people who worked in my team had that in their heads where they're making those clinical decisions.
Thank you very much for clarifying that.
Thank you very much. Thank you for your useful questions there. Any more questions? Any more? Right. Well, thank you very much for, going through those very difficult challenges that you faced with us. And thank you for your report, and good luck with
Thank you very much, Chair.
Your work and all that you've got to rectify. But I'm sure you'll get there, and we look forward to hearing more in the future. I think we were thinking maybe some feedback in about 3 months, weren't we? So hopefully we'll be seeing you again soon. And
great. Look forward to it.
Thank you very much, and thanks for your presentation.
Bye.
Bye. Now we move on to item 8. We've got Sarah here to give us an update on integrated care board activities and commissioning plans and the formation of the ICB. Have we got Lisa Shoebridge? She was going to give us a winter plan briefing, but I don't know that she's in the room, is she?
No, so Lisa, sorry, I think there may have been a misunderstanding as to when that update was being brought. So if it's possible for us to bring the winter update to the next meeting, then Lisa and I can come and present the winter planning at that particular one, if that's okay. So if I cover the broader updates, I'll start also, if I could reintroduce Helen Clark, who you will know from a primary care background, but actually she's just moved into a new role as of this week as my deputy. So she's the Deputy Director for Berkshire West on behalf of the ICB. So welcome to Helen, and you may be seeing her at these meetings as well going forwards. Just to kind of pick some of the key things I wanted to update you on our integrated care board. But before I do that, I think, apologies if this is oversimplifying things, but I know the health landscape can be a bit complicated. So just to help position our organisation in the wider context. So generally NHS organisations can be categorised as those that provide services and provide care. So your hospitals, your community service providers, and your GP organisations, etc. And then those that plan, commission, and do the longer term strategic planning for healthcare services, which is where the Integrated Care Board comes in. It was previously 3 separate clinical commissioning groups that undertook that role, one for Oxfordshire, one for Buckinghamshire, and one for Berkshire West. And now we've come together as one organisation called the BOB ICB, Integrated Care Board. And my role within that, I'm the lead exec director within the ICB representing Berkshire West. So I don't know if that helps to clarify some of the slightly muddy health landscape at times following the latest reorganisation. But that's for context for those councillors that may be slightly newer to this arena. So a few points I just wanted to update the committee on in terms of a broader ICB update. So we have recently welcomed Dr. Nick Broughton in as our new interim chief executive. He was previously, well, he is substantively the chief executive at Oxford Health, which is the community mental health provider in Oxfordshire. And he's joined us on an initial 12-month interim basis to provide some continuity of our leadership as we continue to then progress a substantive employment process. And so he's come in with a lot of enthusiasm and a lot of experience coming from an NHS provider landscape as well, but also from working in communities and with partners very locally. So that's great to have Nick on board. To recap on some of the key things that have been achieved over the last few months. So the Integrated Care Partnership, which is, I suppose a way to describe it is kind of the governing body, non-executive committee of which Councillor Macro now attends, providing oversight across the whole BOB patch. So that has representatives from all of our local authorities and ourselves as the ICB. We confirmed our strategy, or the ICP confirmed the ICP strategy that we were all signed up to. And recently we've, from an NHS perspective, confirmed our 5-year joint plan for delivering our elements of that strategy. And that's been published. And if it's helpful, I can share and circulate the link to that plan as well. So that puts some of the flesh on the bones of how we're going to take forward some of the ambitions in that strategy, which centre a lot around how do we keep people well for longer? How do we focus more on prevention as opposed to just treating the symptoms? So how do we make changes now that means that our residents are going to be well for longer and avoid the swelling tide around things such as long-term conditions and the impact that can have on our individuals' well-being. So we're then working through that plan, and we're providing regular updates to our board, which will be public updates and are available to be shared as well. We're continuing to develop what we're calling provider collaboratives across BOB. What this means is at the moment we've got 3 large acute hospitals working in our patch, and they're coming together in a collaborative way to look at areas that actually it would make a lot of sense for them to work together on in terms of it sharing best practice and delivering services for the benefit of our residents. And similarly, our 2 mental health providers are also working more collaboratively in a similar vein to try and generate some of the benefits of scale while it's not losing that really important local focus. So there's been quite a lot of work on developing those collaboratives and making sure we are getting benefits out of the new construct of BOB. And really importantly, we've been continuing to develop our local geographical partnership. So here in Berkshire West, As we touched on before, that means the West Berkshire, Reading and Wokingham geographical areas, bringing in the Royal Berkshire Hospital and Berkshire Healthcare Foundation Trust as well. And I hope colleagues, particularly Paul in the room, would agree that actually the relationships in that partnership are strong and collaborative, and I think we're quite open and transparent with each other as organisations. I know the findings from the continuing healthcare review identified some concerns, but I feel that those are more limited to that particular service area, which is one aspect of what we do. The wider partnership, I feel that we're in quite a strong place in terms of the conversations and the maturity that we're having. And we've got a programme of work that we're working through in terms of some priority areas that we think actually it makes sense for us all to come together on, because there's benefits to be had by working together and chasing shared opportunities. So one of those we touched on earlier in the primary care update around our community wellness outreach model. So this is where we're bringing together general practice, local authorities, the voluntary sector, and our community, really importantly, our kind of community base, our community assets, places that people already go to and trust. And then we're taking services to them. So we're just in the final stages of hopefully commissioning this service, where we'll have teams that will be going out to community cafes, libraries, public spaces to really engage with those communities that need us to go to them, to start having those wider wellbeing conversations, and really importantly, be able to then signpost them or book them in to follow-up appointments where that might be necessary for sort of that onward support. So if the initial health check identifies something that requires a conversation with their GP, we'll be able to arrange that as well. And really taking that into initially those communities identified in the kind of core 20+5 demographics, and then hopefully being able to scale up depending on the outputs of this pilot that we're running at the moment. So really excited to be able to take that forward. And I think that truly has been an integrated partnership proposal. It's been discussed and shaped really through the locality integration boards. And we will be reporting back on that predominantly through the health and wellbeing boards, but clearly we can bring updates through this committee as well if that's helpful. Another area of focus is around continuing healthcare, and we've obviously just heard about that now. And same-day urgent access as well as another priority area that we're focused on around how do we, linking with all the work that's happening in primary care to improve access into general practice. How do we make sure we're offering our residents the best services and the easiest access where we've got same-day urgent needs, so that unless people really need to go to A&E, they don't feel that that's their only option at times. So a piece of work that we're developing as partners on that. And there are a number of others. I won't go through all of them in detail today, but if it's helpful for me to provide a written update on those for the next committee, then I'm very happy to do so. On the topic of urgent access, we're also looking at our planning for winter, and I think we're on the front foot this year because we were having conversations right back from April around the funding that we had available for winter pressures, and how we wanted to best deploy that to support services and residents throughout the winter. So we're continuing with that, and as I mentioned before, be very happy to come back to the next meeting to provide a more comprehensive update on specifically what that looks like, and what our expectations are for this winter period going forwards. And then just a couple of more operational points. So obviously that you will be aware that the COVID vaccination programme is now rolling out. So we're doing a lot of work to coordinate that, and continuing to support our providers to manage the ongoing periods of industrial action that we are facing, predominantly junior doctors and consultants, and recently radiology colleagues as well. So just to provide a level of reassurance that there's an awful lot of oversight and quality scrutiny to make sure that the services that we are able to run during periods of industrial action are safe, and that our residents are going to be safe if they need our services. So that's a bit of in a nutshell updates around some of the ICB activities recently. Very happy to take any questions, or if there's any other areas that members want to ask, very happy to cover those.
Thank you for that, Sarah. Thank you. Yeah, it's good to hear the collaboration between the hospitals. You tend to think of them as just large independent entities. So the word collaboration, that's good to hear. I mean, personally, I'd like to see more outreach services at our own local community hospital here in West Berkshire. It's such a great facility, with potential to grow. And from the point of view of local people in West Berkshire, that would be, for many of us, that would be a much more friendly and accessible service if we could have a bit more outreach from the larger hospitals when people need aftercare, rather than trekking all the way back to the main hospital.
Yeah, and I know that's something that colleagues at Berkshire Healthcare and Royal Berkshire are looking at on a regular basis. There's still ongoing considerations around if we secure funding for a redevelopment of the Royal Berkshire Hospital site, what that means and what that might look like. No decisions have been made yet, so I can't confirm in any kind of detail in terms of whether we're getting the funding and when and what that looks like. But clearly a key consideration of that is what services do need to be consolidated on a site, and what services can we deliver in a way that is much, much closer to the heart of our communities. So that is very much front and centre of those conversations that we're having at the moment.
Very much. Yes, Councillor Foote.
Thanks very much, Chair. Just a very quick question. You mentioned about sort of outreach and accessibility, and how you're looking to try and increase prevention programs, etc., etc. Obviously, you won't need me to tell you that across the council, everyone's extremely strapped for cash. I'm thinking if, for example, there was a program of outreach in an establishment that was owned by West Berkshire but was being used predominantly for another purpose. I'm thinking, just off the top of my head, something like a library, for example. Is there any scope for funding from your end being fed into that that part of the council? Because obviously, space, I mean, there is a cost. People might have to be, physically employed, doing something if there's a health outreach. Is there any way of cross collaboration with funding for that sort of thing? Thanks.
No, thank you. And that's a really good question. It's something that we have been discussing as a kind of a leadership collective, is how do we make better use of the space that we already own? And therefore, if it's leasing space from each other, what does that look like, and making sure that we are reimbursing appropriately? I think it's the right question to ask, and something that we'll be looking at through each individual programme. But I do think it's really important that before we look to sort of private leases or redevelopment of areas, we do that check on what do we already have and what can we already use that's within public ownership, whether that's NHS, local authority, or also include the voluntary sector within that consideration.
Thank you very much. Thank you.
Thank you, Councillor Foote. Thank you, Sarah, for your report. Thank you very much indeed. Thank you. Members, please note Sarah's report. We haven't got any recommendations concerning it. Thank you. Right, we now move on to item 9. Fiona's been sitting there quietly all this time. So I now invite Fiona Warby from Healthwatch to speak on her report, which is on page 73 of your packs. Thank you.
Thank you, Councillor Vickers. Good afternoon. Hello. In Healthwatch West Berkshire at the moment, I've relatively new in post. I've only been in lead post for 4 months now, I think. So I'm still getting my feet under the table, as it were, and sort of finding out what's happening out in the world. However, we're having a refresh of Healthwatch West Berkshire within the service providers. We have been out to all of the dentists and all of the surgeries in West Berkshire now, and we hopefully should have our posters up and some information about how to feed back to Healthwatch out in the public. We are currently waiting, hopefully, to be able to get onto the screens in the GP surgeries, in the practices themselves. I think there's a little bit of a confusion there about who actually looks after them. So we're kind of going round at the moment trying to find out who is responsible for putting things on the back of the surgeries, so the people in the surgery, whoever they may be, can allow us to advertise on their screens. So that's something that we're doing at the moment. We're also being out and about in the voluntary sector. We're also going out and we're meeting lots of people out in vulnerable groups. So we're going out this week, actually. We're going to 8 Bells Mental Health to say hello and introduce ourselves. And we are taking down the information about our new project, which I'd like to tell you a little bit about. So in April this year, we put out, which I explained about at the last Scrutiny board meeting, a project. It was a survey just asking the public. It was a very short-term survey asking the public about what their health priorities would be for the coming year. And we had 127 responses, and basically the responses to that was they wanted us to look at GP access and GP services. Now, we did this in working alongside Healthwatch Wokingham and Healthwatch Reading as well. It was a joint project, and across the board we all had very, very, very similar responses. It was one was GP access to or GP quality of, and all across the same. So we are now doing a joint project going forward, which we are just starting now, which is called the GP access, and we are literally having a focus groups, lots and lots of focus groups in each area. We're going out to speak to the PPGs from each surgery and asking to meet with a certain amount of members of the PPGs, if we can speak to them as a focus group under each PCN. And then what we will be doing is we will be going out to the vulnerable groups as well and taking a survey with us, which will have exactly the same questions. So we've kind of designed some questions between the three of us in collaboration with doctors and Bob, as was mentioned earlier. And we will be going out at the end of this month, fully out into the areas, and we will be advertising for the people to come out to see us. We have our focus groups. We have all of us have got focus group dates booked in our calendars now, and we're going to start doing the invitations very soon. We're quite looking forward to it. It's going to be quite interesting. We've had a lot of feedback from the survey that kind of said, we don't know what's going on with the new way of working. We're very confused about things. We don't understand the receptionist role now. We're told that it's changed, but we're also quite aware that there's not a lot of comms has come out, or the comms that has come out has been sparse and not incredibly clear to people. So we want to speak to everybody to ensure that we're going to get the right questions answered for everybody to take some feedback from, to kind of get these. Perhaps I think it's going to be more comms than anything else. However, until we get out into the public, we're not 100% sure. So we're very much looking forward to that. We will be doing the analysis in February and the report coming out in March next year. So that's where we are with the GP access report. And we have now finished our work plan, and it has been published on our website. If you'd care to look at the website, it will be in full there now. And as I said, we are still monitoring comments on pharmacies and subscription services. There's been quite a few issues recently around several of the pharmacies, especially with them closing, and lots of queries around a specific phlebotomy in Hungerford has been coming over to us. So we are kind of looking out on that. We're also very aware of phlebotomy services. There's a little bit more information coming through at the moment about long delays to get appointments for phlebotomy. However, it's difficult because I believe that there's been some staff shortages, but again, it's something that we're monitoring along with the A&E service and the Building Berkshire Together developments. So over and above as well, we're kind of taking into account on anything that we do, the cost of living impact. So we know that there's obviously something going on with the cost of living across across all of the nationwide, but with health, is there an issue? Are people not paying for their prescriptions because they can't afford them? There's lots and lots of things. We've heard things like this. There's lots and lots of different types of impact that people they're not going to their appointments because they can't afford to get there, they can't afford to take a taxi, they can't afford to phone for their, if they're on hold waiting. A lot of people have pay-as-you-go phones, and if they're on hold for a long time, it costs them a lot of money. So all of these questions will hopefully be coming out in our GP Access report. So that's where we are at the moment. Thank you.
Thank you very much, Fiona. There's a lot going on.
There is a lot going on, yes, indeed.
Small team is working very hard, and interesting to see that your work and your comments are sort of tallying with what's happening in other areas. Helen's nodding her head. Do you want to comment at all, Helen, on Fiona? What's Fiona said?
Yeah, just a couple of things, if that's okay. Firstly, with regard to the screens, I'm happy to have a conversation as to whether we can unpick some of that with you. And secondly, just to recognise, I mean, the ICB has been working quite closely with Healthwatch around this patient GP Access project, linking particularly with our comms leads. I think we really welcome the work that's being undertaken. I think it will be really helpful to all of us in terms of understanding patient perceptions of current access to general practice, and also supporting how we get some of the messages across, which we've already discussed today, particularly around different ways of accessing practices and how different groups can go about that, and also with regard to the different roles that we're now seeing in primary care, which are perhaps different to those that historically were part of the team. So yeah, just positive, really. We look forward to continuing to work with you on this area.
Absolutely, thank you.
Well, thank you again for your report, Fiona. Members, have you got any comments or questions? No? Thank you. Well, thank you. Thank you very much, and good luck with your programme. Thank you. Right, we now move on to item 10, task and finish group updates. This is on page 77. Of your agenda, and just to see where we are with our programme. What we covered today is listed there, and our subjects for December, when we'll be looking at emotional well-being of children and children and young people's mental health services and maternal mental health. So that's in December, and our programme following that, we'll be looking at further suggestions and further issues. Can I just ask? Might be an obvious question. What is an inquest review panel? Is that just individual? I'm asking. Ask Paul.
It might be worth us talking offline about this, Chair. Essentially, it was generated in response to a number of inquests that had come through affecting people that the council was working with. Naturally, I think we brought a report which was relatively kind of high level on the basis that this is a public meeting, we didn't want to cause further distress to families that are affected. So we can work out, I think this would be the second time that such a paper has come forward. So maybe if you could review the last paper and see if you were content that it did something useful.
Thank you. Right, thank you very much. So we're just noting that. Oh, just to note that there's a form on the website which allows people to nominate topics for health scrutiny, just in case anybody out there is listening, and for members also. So for our future programmes, we're constantly looking at making sure we're focusing on things that are relevant to local people, and the best way of doing that is to get input from our local community. So please get in touch if you want to suggest topics, and any way of helping us to, increase our profile in the community and our access. Thank you very much indeed. I think that anybody got any comments on that or any? No? Thank you. So I think that's the end of our business, unless I've left something out. So thank you everybody for your engaging and for your interesting questions, and thank you to our participants, those that are left on screen. Thank you for attending, and thank you for your hard work, and look forward to seeing you again in the future. So thank you very much. Thank you to officers as well. Thank you to Gordon, Vicky, and to Paul. Thank you and goodbye.